Endocrine system. All diseases or syndromes of the endocrine system are the result of an excess or deficit in the production of hormones. We will begin with diabetes insipidus and SIADH, syndrome of antidiuretic hormone. Hormones maintain and regulate body systems. They act on specific target cells regulating physiologic function. A primary disorder has to do with the gland itself. Abnormality with the pituitary. Posterior pituitary hormones, antidiuretic hormone, vasopressin, ADH, and oxytocin. On the anterior pituitary hormone and their releasing inhibiting hormones, there is growth hormone, TSH, thyroid stimulating hormone, ACTH, adrenocorticotropic hormone, prolactin and gonadotropin, luteinizing hormone, and follicle stimulating hormone. Secondary, the pituitary or other sources, ADH, aka vasopressin, stimulates water retention by kidneys, inhibits sweat glands in skin, stimulates vasoconstriction in skin, hence named the vasopressin, which is also known as ADH. Antidiuretic hormone. We have the picture here with the regulation. Number 1, high blood osmotic pressure stimulates hypothalamic osmoreceptors. Number 2, osmoreceptors activate the neurosecretory cells that synthesize and release ADH. 3, nerve impulses liberate ADH from axon terminals in the posterior pituitary into the bloodstream. 5, or we have 4 down here. Kidneys retain more water, which decreases urine output. This is all action of the ADH. Target tissues. Pseudoriferous sweat glands decrease water loss by perspiration from the skin. Arterioles constrict, which increases the blood pressure. Number 5, low blood osmotic pressure inhibits hypothalamic osmoreceptors. And then number 6, inhibition of osmoreceptors reduces or stops ADH secretion. This is all the ADH regulation on slide number 6. ADH, excess of hormone, results in syndrome of inappropriate ADH, SIADH. So too much ADH is when you have SIADH. Deficit of ADH results in diabetes insipidus, DI. What is diabetes insipidus, DI? Water metabolism problem caused by antidiuretic hormone, ADH deficiency, or inability of the kidneys to respond to ADH. Diabetes insipidus, what we have here is the pituitary gland. We have the kidney. Pituitary gland produces insufficient ADH, hence the kidneys make a lot of urine. Because you don't have that antidiuretic hormone, it doesn't stop the diuresis, so you just keep peeing urine. Difference is that DI has large amounts of dilute urine, which is excreted. Distal kidney tubules and collecting ducts do not reabsorb water. Polyuria occurs, which patient loses lots of urine. Dehydration and electrolyte imbalances result. Slide 8. What are the different types of DI? Well, there's diabetes insipidus, which is classified as nephrogenic. That's the kidneys do not respond to ADH. You could have primary cause, decrease in production of ADH, either post-pituitary gland or hypothalamus in the brain, problem with the gland. Secondary would be central, like tumors, a head trauma, infections, or surgical procedures that are stopping this ADH drug related, such as lithium or D-meclocycline. Psychogenic would be compulsive fluid intake associated like with psychiatric schizophrenia overwhelming need to drink lots of water. Slide 9 on PowerPoint. Assessment findings for a client with DI. Signs and symptoms of DI are related to having dehydration from peeing out so much urine. Increase in frequency of urination and excessive thirst is a symptom. CV changes, typically hypotensive, decreased pulse, pressure, tachycardia. These are cardiovascular changes. Pulses are rapid and weak. Rapid is in trying to compensate for the dehydration, but they're weak because you're dehydrated. Labs would include H&H, hematocrit and hemoglobin, and BUN would all be increased, concentrated because of this dehydration. You wouldn't have a lot of fluid left. Renal and GU, increased urine output. Urine has a low specific gravity because it's so dilute. Skin would be dry skin, poor skin turgor, dehydration. Neuro would include, you would have thirst, irritability, decreased concentration and focus, ataxic gait, or as well as hyperthermia. Results of laboratory testing for DI. Urine, think dilute, so decreased urine specific gravity. Decreased urine osmolarity, decreased urine pH, decreased urine sodium, decreased urine potassium. As urine volume decreases, urine osmolarity decreases. Blood, think concentrated, increased blood osmolarity, increased blood sodium, increased blood potassium. As blood volume decreases, blood osmolarity increases. BUN and hemoglobin, hematocrit is increased. Slide 11. How is DI, diabetes insipidus, diagnosed? You can test serum ADH. Normal levels are 1 to 5 pg dot per milliliter. This differentiates between nephrogenic versus neurogenic cause. Increased ADH would be nephrogenic diabetes insipidus, DI. A decreased ADH would be that you're having a neurogenic DI, which was, if you refer back here, nephrogenic kidneys are not responding to ADH. And then, so you had primary or secondary causes. Going back to the slide 11 here. So increased ADH with nephrogenic DI, neurogenic DI is decreased ADH test results. Urine osmolarity decreased, low blood ADH level. Specific gravity decreased. Water deprivation test is very time consuming. It requires a controlled setting. It measures the kidney's ability to concentrate urine in light of an increased plasma osmolarity of a low blood ADH level. Identifies causes of DI. You can figure out whether it's nephrogenic central cause or psychogenic. Water deprivation test helps decipher between the type of DI. Time-intensive and labor-intensive tests. Procedure, no fluid for 8 to 12 hours. Client's weight measured hourly. Provider may prescribe weight loss 3 to 5%. Serum osmolarity measured every hour until 3 separate checks show an increase of less than 30 mmol per kilogram, which ensures dehydration. For accurate test results, blood osmolarity is greater than 288 mosm per kilogram dose. ADH is administered sub-Q. Urine osmolarity is measured 30 to 60 minutes later. Water deprivation test results are the nephrogenic DI, central DI. With nephrogenic, little to no increase in urine osmolarity during the test of Following ADH administration, central DI, rise in osmolarity of more than 9% following administration of vasopressin. Psychogenic, minimal to no increase in urine osmolarity and take longer to become dehydrated. What medications are prescribed for DI? They're aimed at increasing the amount of ADH. Oral chlorpropamide. This medication stimulates production of ADH. Side effects are hypoglycemia, measure blood glucose level. Desmopressin, which would be DDAVP, is a medication for DI. Desmopressin acetate intranasally, orally, or by injection, which replaces the missing ADH and decreases urination. Dosage with DDAVP depends on patient response. Nasally could need multiple doses throughout the day to maintain ADH. Side effects: alteration of mucous membranes, chest tightness, lung inhalation of the spray, severe deficiency in ADH, can be given IV or IM injection. What should be included in the plan of care for a client with DI? Early detection of dehydration and maintenance of adequate hydration. So vital signs, check urinary output, specific gravity on the urine, intake and output, monitor that, and electrolytes. Weigh client daily. Notify doctor of weight gain greater than 0.9 kilograms. Remember, it's 2.2 pounds per kilogram. Regular diet with restriction of food, fluids that exert a diuretic effect. Example, like caffeine, chocolates, anything that exerts that diuretic effect. You'd want to avoid that because they're already having a lot of diuresis. Drink fluids in response to thirst and match the volume of urine output. Lifelong desmopressin is a lifelong therapy, aka vasopressin, which is desmopressin, the medication to replace that ADH. Therapy for clients with permanent condition of diabetes insipidus. What education on DDA, VP, admin, intranasally would you give a patient? Sit upright, shake the bottle, nares and inject number of sprays into each nostril. Nephrogenic DI, chloropropamide and thiazide diuretics facilitate vasopressin action, can reduce the urine output. Prostaglandin inhibitors and mild salt depletion cause ADH effect. Example is indomethacin. What is the syndrome of inappropriate antidiuretic hormone secretion? So we're moving on to SIADH, and we're going to do that in the next video. Thank you.